Hello, good morning or good afternoon, depending on where you live. Thank you very much for joining us today for our webinar, Strategies for Success, Implementing the ASCO Exercise, Nutrition, and Weight Management Guidelines with Your Patients and Practice. This webinar is part of our Survivorship Champions program, which is NCCS's program for clinicians and researchers who are interested in improving care for cancer survivors. I'm thrilled today to welcome our two speakers. Sammy Mansfield is the founder of Cancer Wellness for Life, and Dr. Wendy DeMark-Wanafried is a professor of nutrition sciences at the University of Alabama at Birmingham. And rather than read their entire bios, I'm just going to give you that short bio, and we have a link to where you can read their more detailed bio, but I want to have as much time as possible for their presentation, which they've worked very hard on, and we are really excited about this. This is a very important topic. First of all, we had record registrations for this webinar, so we know that it's important, and the registrations are mainly from healthcare providers, but there also are advocates and cancer survivors and caregivers. They're aware, our speakers are aware of that. While this is targeted to how to use this information in clinical care of cancer patients and survivors, I think that information will be useful for advocates and survivors and caregivers as well. We also know this is a really important topic because in our State of Cancer Survivorship Survey, we hear from cancer survivors that maintaining a healthy weight, exercise, and nutrition are top concerns for them. And there are also areas where they don't always feel like they're getting the support they need from their healthcare team. So we're really excited to learn more about these guidelines and not just about the guidelines, but how to use it in practice. So thank you so much, Sammy and Wendy, for joining us. And I'm going to turn it over to you for your presentation.
Thank you so much for having us. And we're really excited to be here today. Wendy, do you want to say anything before we get started into the slide deck?
No, just thank you. It's a pleasure to be here.
Excellent. So why are we here, or what is our objectives for today? We have two primary objectives. Our first objective is most important, is our updates in the evidence. As you heard, we are going to highlight the recently published ASCO Guidelines, which is regarding the patient population during treatment of curative intent. But we realize that this is a very narrow window for a lot of the individuals here that are participating either as a clinician or a patient. So we are going to broaden these recommendations to reiterate the WCRF, AICR, and ACS guidelines. And then the other piece that we are excited about being here today is not only are we going to talk about the evidence, but that we're going to shift into implementation. Because I think we all know that these pieces of cancer care are important, but implementing them into the various roles that you have as a clinician, as an allied healthcare professional, if you're a cancer survivor or caregiver, are also really important. And we want to provide some useful strategies there as well. And we will give patient examples as well as resources, references, etc. So Shelley mentioned this coming into our presentation, but why are we here? Well, we know from NCCS as an advocacy organization that not only is it living after cancer being alive, but it is quality of life and how important survivorship is focused on living well after cancer. For the sake of our conversation today, we are going to use the words cancer survivor in the same terminology as NCCS does, that anyone living with a diagnosis after cancer, they could be in treatment or they could be with metastatic disease. We're going to bucket that into the cancer survivor, and then we'll focus on some target populations through our talk. But the State of Survivorship Survey summary reiterates the importance of these guidelines and implementation. This was the 2022 survey that was presented at the end of October. If you haven't seen this, if you're new to this webinar series, make sure you go back and take a deep dive through this presentation. It was very comprehensive and extremely helpful representing the data. But in this survey, survivors called for a focus on mental and physical health. They focused on interest in exercise, nutrition, as well as strategies to reduce pain and fatigue, which exercise plays a key role in. And so as an oncology exercise professional, this makes me very happy to see. We also had a highlight on integrative oncology opportunities that survivors were really seeking information in. And these you can see listed here were broad, but also a bit specific. So yes, exercise, but also looking at things like dietary or massage and mindfulness, and wanting to find strategies that improve not only quantity of life, but quality. Again, as an exercise professional, I would like to reiterate that I see that exercise should be really moving towards standard of care for reasons we'll discuss today. So I know that often we think about it as integrative or supportive, yet function is everything. And we've all actually needed function today to get to where we are. So I think it's an important piece of this discussion. And we know that survivors need information, they need education, they need real evidence, not just something that they're going to find on online resources or just talking to people randomly. So let's start with the ASCO guidelines. So these were the guidelines, as we mentioned, that were published just this past May of 2022. These were focused on during treatment and only focused on patients that were on active treatment with curative intent. And so we looked at, as an author panel, 53 systematic reviews, tripped over that word, and 23 randomized control trials. Actually, 3/4 of these were in exercise. And we realized that the significance of exercise should be part of standard of care for patients on active treatment. This is definitely new to recommendations, and so something that's a very exciting addition. It was recommended through the ASCO guidelines that oncology providers should recommend aerobic and resistance exercise because of the benefits related to things like toxicity, specifically fatigue, improving things like muscular strength, cardiorespiratory fitness, and simply function. And I think it's important to note and not reiterate it enough that exercise is very important for quality of life and mood. And this was highlighted in the evidence that we reviewed for the ASCO guidelines. I'll talk about exercise a little bit further down the road here, but this was one of the first recommendations that we've seen that reiterates the importance of the multimodality aspects of exercise with aerobic and resistance. And I think that's of importance to note, because it isn't just taking a walk, it is taking a walk, but also making sure that you have strengthening.
So I'm going to take the dietary recommendations, which, as Sammy pointed out, the evidence behind them is much smaller. Only 7 studies. And because there were only 7 studies during this narrow time of treatment, we really don't have the data on which we can make recommendations. That being said, we were able to find that neutropenic diets are not recommended. So any of you that are restricting fresh fruits and vegetables in patients that are receiving active treatment, please do not do this, because it's actually associated with more harm than good. So that's one thing that came out of these recommendations. There is right now insufficient evidence to recommend either weight loss or weight gain prevention during this time of treatment. Again, that's not because those recommendations are not important. We just don't know. We don't have enough research, and this is an area where research really needs to be done. So where we have more evidence is in the area of cancer prevention and also cancer survivorship beyond the period of treatment. And here we have recommendations that are set by the World Cancer Research Fund, American Institute of Cancer Research, as well as the American Cancer Society. Now, the WCRF AICR is really the mothership of these recommendations. And so the American Cancer Society really takes the lead from them to make their recommendations. And that's why you see so many similarities between the two. I'm going to run through this list and then really kind of talk about the evidence that supports them. So at the very top, because there's more evidence in this area than all others, weight. Be a healthy weight, avoid weight gain during adulthood. And that is the uppermost recommendation by both of these organizations. Secondly, dietary pattern. Eat a diet that's rich in whole grains, fruits, vegetables, beans, and that's considered what's called a prudent diet. And if you scan over to the ACS recommendations, they make more specific recommendations in that Yes, you need more fruits and vegetables, but try to eat a variety of colors of those fruits and vegetables. Make sure that you eat whole grains. And then both of those recommendations reinforce the need to limit fast foods, refined foods, high sugar, sugar-sweetened beverages, and to avoid red and processed meats. Now, the World Health Organization endorsed, or not endorsed, but basically came out with the statement that processed meats, meaning sausage, bacon, hot dogs, those types of things, are a known carcinogen. It's a class A, 1A carcinogen. So to limit those as much as possible. Red meat's a 2A designation, which means that you should limit. And for women, 12 ounces a week is what's considered the top. And for men, 18 ounces a week is considered the top. Then alcohol. Limiting alcohol were the recommendations from the WCRF AICR. The ACS doubled down on these later because there was less evidence that alcohol was actually cardioprotective and more evidence that alcohol is harmful. And we'll go into that a little bit later. And then both recommendations: be physically active and to really pursue aerobic activity as well as strength training, and to avoid sedentary behavior. So the evidence behind these guidelines, and I could be talking on this all day, but I'm going to just pick out some salient slides. So we know that once a person's been diagnosed with cancer, they're at much higher risk for a second cancer. And because of that, I'm featuring these data on obesity and relative risk of cancer, because yeah, you might have survived the first cancer, but the second cancer might be coming down the line. And there are 13 different cancers for which obesity is considered a risk factor. And those are all aligned on the x-axis there below. Endometrial cancer has the strongest association. You see there a 700-time more risk if one is obese as opposed to normal weight. As you get to the right of the chart, postmenopausal breast cancer, ovarian cancer, thyroid cancer, the risk is only 10% greater, but it's a very stable estimate. And so we have to be attentive to those data. Next slide. We also know that obesity is tied in with cancer mortality from the point of diagnosis. So here are the tree charts for 15 different cancers, which show that if one comes into diagnosis with obesity, it's a poor prognostic factor. And then finally, weight gain. So many people gain weight during the time of treatment, particularly if they're treated with hormonal agents as well as chemotherapy. So the very first set of studies, meta-analyses that was done by June Chan, there are 82 different studies, over 200,000 women with breast cancer, show that individuals that gain a BMI unit, it is associated with a 29% increase in breast cancer mortality, an 8% increase in total mortality. For prostate cancer, a meta-analysis shows that biochemical recurrence, meaning men whose PSA rises after they've had definitive treatment, for every BMI increase, up 21% risk for that outcome. And then for prostate cancer specific mortality, up 20%. What we don't know is, will weight loss necessarily decrease risk? We know that increasing weight increases risk. We don't know at this point in time, does definitive weight loss decrease risk? And here we're drawing on data, hopefully that will be coming from the LIV study that's being done in ovarian cancer, as well as the Be Well study that is being done in breast cancer. So moving on to diet quality. How important is it to eat right? Well, a meta-analysis here of 113 studies and more than 3 million people show the data are pretty clear. Overall mortality decreases about 20% for that person that follows that prudent diet, as opposed to those that don't. If I direct your attention over to the right-hand side of the screen, with regard to cancer, those data for cancer prevention are a little bit weaker, but still very strong, about a 14% decreased risk. For cancer survivors and the mortality that they experience, about 18%, and overall cancer mortality, 17%. So eating a good diet that's high in fruits, vegetables, whole grains, low in meat, low in sugar is important. And just as a note, you don't have to eat fresh fruits and vegetables. Canned is all right. Frozen's a little bit better. And so it doesn't have to be fresh fruits and vegetables. Next slide. Lastly, alcohol. I really don't like presenting this because I love my glass of wine at the end of the day. But the data are what the data are. And the data suggests that alcohol is linked with head and neck cancer, breast cancer, liver cancer, and colorectal cancer. It damages cells. It has a synergistic effect with tobacco. So the both of them together are really deadly. It does affect hormones related to breast cancer, estrogen. If those of you that are postmenopausal women that have drinking a glass of red wine, know it. You feel it when that red wine kicks into your system. You have a release of estrogen. And it does break down, that alcohol breaks down to cancer-causing chemicals. As I said, the data are becoming weaker with regard to any sort of cardioprotective effect. So now we know that the data are pretty strong with regard to a linear risk with cancer. So if you do drink, well, find another lifestyle behavior that you can pick up, like physical activity, to make a balance here, because the alcohol is not doing any favors.
On that note, we'll switch to exercise and physical activity, which can be a great tool for stress management, as well as some of the other things that we drink our glass of wine for. So this is a slide introducing some of the recommendations and lifestyle behavioral strategies around exercise and physical activity. And before I take a deep dive, I want to give a little framework to some of the words that we use and what they mean, and then what the evidence actually is using, because I think it is very important when we're providing implementation strategies. So physical activity is anything that we do to move. So for everyone, we're getting here today by some form of physical activity. And one of the base recommendations for all of the guidelines is to reduce inactivity or true time spent doing nothing. So you can move in a chair or in a bed, but we want to look at reducing just pure time where we're not doing any form of movement. So that general physical activity aspect. But exercise is a bit more specific, and especially in the evidence, that it has a plan, a purpose, a goal, and intention. So it could be walking the dog. It could be doing a flight of stairs, but exercise means a lot of things and has a lot of different modalities, but the guidelines are specific that we want to strive for 150 minutes of moderate or to 75 minutes of vigorous physical activity, or I'm sorry, exercise weekly. That does include 2 times of resistance or strengthening exercise each week. So if I break this down, this means if I'm going to do 150 minutes of moderate, that will include my resistance exercise at a tempo that I feel a little bit out of breath, but that I can sustain for a duration of time. If you exercise 3 times a week, that's about 30 minutes. It can be broken up in sessions. It is really what fits into your life. Or you can strive to do something a little more vigorous, a little bit more breathy, something that makes you feel a little bit more muscle tired or fatigue. And if you want to work a little bit at that intensity, you actually can do less, 75 minutes, which breaks down to 15 minutes 5 times a week. I want to reiterate that this is not recommendations based upon things like age. This is completely based on how hard you are able to push yourself in any aspect, from being vertical or being in a chair. I do want to share some of the true outcomes that we know regarding exercise, which for myself and doing this work for 20 years, this is very exciting. to see, truly knowing that the evidence shows that the #1 most reported side effect of cancer treatments is fatigue, and exercise is a key strategy to manage fatigue, health-related quality of life, really reiterates the work that NCCS is doing, as well as function, balance, etc. And then thinking about mental health benefits such as anxiety, depression, and sleep. So again, looking for some healthy strategies that you can implement into your life. I do want to reiterate, because I think this is a key for many of our survivors, if not all, will exercise improve my survival? Well, the data is very clear. We definitely can't say this across every type of cancer, but we have strong data that supports that in meeting exercise guidelines improves survival for breast, colon, and prostate cancer. So it's one more tool in your tool belt to improve your outcomes. Take a look at the pyramid on the right as just a little bit of a framework for implementation. It's important to increase your daily movement. But again, this can be anything. It can be fun. It can be gardening. It could be dancing in your kitchen. It doesn't have to always be lifting a weight at the gym. I think it's important to note that exercise can be a lot of different types of modalities. So what else do we know about exercise? Well, meeting these guidelines has other diverse benefits, including risk reduction and severity of many other chronic diseases, including cardiovascular disease, diabetes, and stroke. For cancer survivors, cardiovascular disease risk is definitely known to be increased after many types of cancer. And so this is another strategy for risk reduction. For function and lifestyle, there's many other benefits for reducing fall risk, improving your activities of daily living, making that load of laundry a little bit easier, and other areas such as joint pain, which is very common in our older adults, as well as a lot of our cancer survivors that might take a hormone blocking medication. So what exactly should I do? I want to reiterate that there is not an exercise prescription for cancer specific types such as breast or colon or multiple myeloma or pancreatic. And that is okay, because it allows us to create personalization for you as an individual or the cancer survivors you are taking care of to find the right type of exercise that works for them. It is noted that more activity appears to lead to more improvement. However, don't underestimate the benefits and the evidence behind small bouts of activity for all of us, including 1 minute bursts of movement, one quick flight of stairs, or 1 minute of standing up from your chair. Small amounts of exercise are shown to improve physical and mental health. And although they may not improve cancer survival, there are simple things that we can do on a daily basis to help ourselves feel better and to help integrate to meeting those recommendations. I also want to make a note that there are some new areas of research that are exciting in the cancer population. Recently, another paper was written about guidelines related to exercise with bone metastasis. This was a secondary bone met from things like our cancer types such as breast or lung, as well as multiple myeloma. And what we realized is that actually these cancer survivors should be exercising. They should be trying to get stronger, improve their balance and falls. And actually the benefits of exercise greatly outweighed the risk. And so something that we should reiterate as a new expansion of the evidence.
So where do cancer survivors start out? We know that there's a lot of work to be done because depending upon the cancer, anywhere from 59 to 63% of cancers have overweight or obesity. Most are inactive. Most do not eat 5 servings of fruits and vegetables, nor enough fiber a day. And depending upon the cancer, many have excess intakes of red and processed meat. For alcohol, it's a little bit lower, but still is of concern in some populations, and then also smoking. And we know that 77% of cancer survivors practice multiple bad behaviors. So we not only have to intervene on one behavior, we really need to intervene on many behaviors. So where do you start off? Now, the beautiful thing about cancer, there's very few beautiful things about cancer, but one of the beautiful things is that it actually does provide a teachable moment. People become reflective after their cancer diagnosis. And therefore, it can provide a teachable moment. People do want to know about what can they do as a partner in their care. And I think you saw that in the NCCS survey. People want to know more about nutrition, physical activity. And we know from research that 92% of cancer survivors want to hear about that, what they should do from their oncologist and their care team. Now, where do you start? And probably one of the best tools are the 5 A's that are provided for tobacco cessation. And this is where you can really adapt this tool for diet and exercise. So we're going to run through some examples here. And in doing the 5 A's, I just want to emphasize, you don't have to do this full circle of, ask, advise, assess, assist, and arrange. You can just jump off and hit one of them. And it is much better than not doing anything at all. So we're going to start with fruits and vegetables. And a perfect question is, well, how many servings of fruits and vegetables do you eat per day? Just to open up the conversation. And to assess where people are starting off. The point, and that lets your patient know that you care about this. And then when they give you an answer, if they say, oh, I eat 7 servings a day, well, that's fine. Then you can jump off this pathway and get on to the next thing that you need to do. But if they say, oh, I haven't had a vegetable in a week, then it's really time to advise them that that's not the best thing to do. A very simple message is try, well, I know it may be tough, but I really want you to try eating a rainbow of colors in fresh, frozen, or canned vegetables. Again, and fruits. It doesn't have to be all fresh. Now, listen for the answer, because the person may come back with, your patient may come back with, well, I don't have enough money to eat fresh fruits and vegetables. Well, they don't have to be fresh fruits and vegetables. They can be frozen, they can be canned. You still get benefit from them. And they can be in various foods that you eat. I'm just going to show, not that I'm endorsing progressive soup, but I'm trying to see where it is here. This is my lunch for today. And it is vegetable barley soup. I get 2 servings of vegetables just by eating this. And your patient can, and it's low in cost. So we can work in vegetables and fruits into the diet. Another way is, have you tried substituting cauliflower rice for rice? Assist. Again, if your patient shows interest, you may want to have some brochures online from the AICR, which makes a variety of different brochures that are wonderful, provide great recipes that you could hand people and say, why don't you try doing some of this? And then if they're still interested, arranging with a dietitian if you do have the resource in your medical center. Next slide. Weight management, a little bit tougher. Your patient is one that has a weight issue, or maybe even perhaps you are a little bit self-conscious in bringing up weight. So this is a sensitive issue. So let's just talk about this. Ask, do you know that weight gain is common during treatment? We all battle weight gain, but boy, it's really common during treatment, just to open up the conversation. Again, to take the heat off the patient, you may want to really orient them to the BMI chart. Now, as a nutrition scientist, I understand the BMI chart has some problems with it, but unless you're a trained athlete, it generally works pretty good. And it also is one way, instead of pointing the finger at the patient, to point the finger at the chart and say, here you are, here's your height, here's your weight, this is where you fall on the BMI chart, this is where the high risk falls, and just use that as a means. If the person basically says, well, I don't have a weight issue or that sort of thing, well, say, well, if you're willing to do this, maybe later on, I can help you. But if the person is receptive, then there may be an opportunity to have some very simple tips like, oh, well, people that weigh every day tend to lose weight, which is true. People that write down the foods that they eat, and especially the foods that they eat before they eat them, have a second to think about that Snickers bar and if they're really going to stick it in their mouth or not. So that's the next step on this 5A pathway. And then the later stages, assisting. There are some great websites that Sammy and I are going to get in that tell you about later. And advising, setting up people with a dietitian or giving them a website where they can get some help. It is not your job to be the weight counselor. But it is your job to open up that conversation because weight is prognostic for cancer. So Sammy's going to take it away for physical activity.
Yes, and I think it's important to note that I go back to the NCCS survey results that, I know we don't always want to talk about these things, but what we're hearing is our cancer survivors want to talk about them. So even though it might be uncomfortable to talk about weight or encourage somebody that's tired to exercise, it is important. And it is something that they are asking for from you as a health provider. So let's take the 5As into exercise. And again, I want to start at the ask because, these questions are definitely the opportunity. Asking your patient or those of us that are thinking about getting moving ourselves, are you doing planned exercise such as walking? Because I think that's always the easy, or strengthening. Asking that question and really reiterating it's beyond activities of daily living. Advising the people that you work with, your cancer survivors, that exercise will improve their fatigue and actually can mitigate or slow down functional decline. So the earlier, the better, hence the ASCO guidelines we presented earlier. Really supporting that other side effects that people might struggle with, such as balance related to neuropathy challenges. They should be exercising, not just sitting around. We want to keep them safe and active and functioning. Then I think the next one is really doing the assessment to a point of getting some history of your patient. What is their experience with exercise? Have they met with a physical therapist? Have they tried something in the community? Did they do a group fitness class before that they really liked, or that was horrible for them? What is their history? And maybe that will help you get some framework and open the conversation. And if not, maybe it's general, you can guide them onto what what resources are available. Then we want to make that assist. Really reiterate, we have a great rehab program, or there's a community program that I'm aware of, and reiterate that this is a supportive tool for the person sitting in front of you who isn't sure how to move after their diagnosis of cancer. They're not sure how to manage those side effects or how their body should feel. And then lastly, advise, reiterate that you're going to send that referral, giving them a resource such as Silver Sneakers, which is free for Medicaid patients, guiding them to have these tools, whether they're in person, if they want social support, we know that's important, or online, which is something that COVID has given us a lot more resources, both pros and cons, but definitely more pros in programs like Silver Sneakers people can do from their home, so they don't even have to drive anywhere to access them. So we want to give an example of a patient that you might see in your Julie is our 65-year-old hormonally positive breast cancer survivor. She has a little bit of family history of colon and pancreatic, but no known genetic mutations. She had surgery and treatment, both she had chemotherapy, radiation, and she now will have 10 years of aromatase inhibitor therapy. We all, if we've worked in clinical practice, have had a Julie, okay? I mean, this is kind of a common patient that isn't sure where to start, but definitely wants to live their best quality of life. She's recently retired. She worked in corporate HR, and I chose that as an example because it was probably a sedentary job, and increasingly so in the technology world that we live in. She's gained 10 pounds and has poor body image. She's tired and she has joint aches. So this could be her age, but it also could be her aromatase inhibitor therapy, and we don't know, and it doesn't matter. We want to be able to guide her in general lifestyle. She talks about sleep challenges and a little bit of anxiety about fear of recurrence. She's sedentary. She's kind of walking once in a while. And like many of us, she has a reported sweet tooth. And she reiterated that at diagnosis, she was told to eat anything that she could to not lose weight, which we know and we talked about earlier is definitely an area that we need to do more investigation in, but is something that we're seeing in more and more of our survivors, and something that why the lifestyle strategies are so important. So what do we do with Julie? Well, we want to think about her, giving her recommendations, again, using the 5 A's framework, depending on where you are in the conversation with this individual, to identify what's Julie's why. If she has a fear of recurrence, we know specifically in breast cancer that exercise can improve survival. So educating and informing Julie of that strategy with giving her a place to start is a really an empowering tool for her. Understanding that she can live a better quality of life and improve her prognostic factors is beneficial information that we now have the evidence on. Reiterating that her energy could be because she's lost a lot of muscle. She's a 65-year-old female, so she may not have a lot of muscle to begin with, but this can help her joints and her energy. And then going back to some of the 5 A's, making sure that we're identifying our barriers. Julie may not, again, she might have financial challenges, or maybe that's not her challenge with nutrition or costs related to nutrition, but she has no idea where to start. And so really having an assessment tool of, okay, what's your framework? What, not only your motivation, but identifying what her barriers are to success are really key. And then I think another one here that I'm kind of mentioned under weight management, but doesn't necessarily mean it should be weight management, is how tech savvy are the people that we're working with. We can recommend that they go online, maybe do a YouTube to follow as an exercise video, but if they're not very tech savvy, that is not the right resource for this particular patient as well. And then lastly, we want to think about sustainability. Getting that point of contact where you get someone excited about making lifestyle change is key, but really helping them come up with framework that's going to help them sustain this in the long haul is definitely going to be really important. Giving them an appointment summary with some of these recommendations or a written prescription of what to do in the conversation is another really great tool that we will with them to identify support, because we hear all of the time that cancer survivors are seeking support. And I think it's important to note that support can mean a lot of things, and one of the key areas could be in healthy lifestyle. So I want to give a program example of a specific actual cancer wellness and lifestyle management program that I helped develop for a healthcare partner in Kansas City, because people ask me all of the time, that's great, but how do we do it? And so I wanted to give this as a framework for an example, comes in the last 5 years. So we integrated a cancer wellness program, exercise and rehab professionals, because we knew in this particular facility that exercise and function was lacking. We had strong dietitians, strong social work, but we didn't have this functional piece. And so these individuals are part of a care team that goes through the 5 A's on a regular basis with patients and caregivers, asking questions and helping to create referrals and recommendations for community resources if we don't have them internally. What have we learned? Well, early awareness of these recommendations are key. The ASCO guidelines actually reiterated this. Patients in the beginning are, what do I do now? And so it is okay to tell them about having healthy diet. It is okay to tell them it's time to move. If we can mitigate decline, we are only helping our patients overall. And then lastly, I would say that collaboration here is key. Working with everybody in our multidisciplinary care teams has definitely been beneficial. I added a website link here if anybody wants to look it up, and I'd be happy to answer any more questions afterwards as well.
Okay, since weight loss is probably one of the things that you want to discuss with your patient, there are no specific recommendations in the AICR or the ACS. However, the organization that makes weight loss recommendations is the Obesity Society, as well as the American College of Cardiology. And these weight loss guidelines come out every 10 years or so, and they review all the literature there. What do those weight loss guidelines say? They say that 3% loss of body weight is associated with a health benefit. So while it would be great if patients got down to their ideal body weight, that is not where the emphasis should be. It's just on see if you can make a 3% weight loss. And then once you make a 3% weight loss, if you want to move on down, that's better. So that's what we should be shooting for. Not, people may get overwhelmed if we say, if they start off at 200 pounds and they have to get down to 120, that is just not going to happen. But if they got down to 180, wow, that's great. That is a victory. What is the rate of weight loss that people should pursue? 2 pounds per week in adults is generally considered safe. But for individuals that are less than 18, if you promote weight loss faster than that, you could stunt their height. Conversely, if people are older than age 60, there is an association between losing muscle mass with higher amounts of weight loss. And therefore, what we recommend in our programs is no more than 1 pound a week in anybody that's 60 and over. The best strategies for this, modest caloric restriction of around 1,200 to 1,800 calories, becoming physically active, and behavior modification. And if you look at that pyramid that's over to the right-hand side, that is the foundation. Behavior modification, diet, and physical activity to weight loss. Now, some individuals who really have higher classes of obesity, they may need pharmacotherapy, they may need surgery, but you start off with this foundation first. And then we know that there are some self-monitoring habits that are associated with weight management. Getting on the scale every day, as brutal as it may sound, is a real key to keeping weight in check and keeping it on the downward slope. The same thing with keeping track of intake. So those tools can be very helpful. Surprising to most people is that there is no recommendation on the distribution of macronutrients. So we should not be saying to our patients, oh, you need to lose weight? Stop eating the carbs, because there is no evidence that a low carb diet works better than a low fat diet, works better than any other diet. So that is a myth that needs to be busted here. And not only do we know that for the general population, there are 2 studies that have been done in cancer survivors that back this up. Next slide. Again, just to reinforce those 5 A's and that you don't have to do all of the 5 cycles. A little dab will do you. Those of you that are as old as I am will remember this from the Brill Cream commercials. But simple things like Lee Jones, who's at Memorial Sloan Kettering, did a study early in his career that just by writing down, please, on a prescription pad, exercise 150 minutes a week, was associated with a significant increase in physical activity. We have found in our studies that among breast cancer survivors, as well as their adult daughters who have obesity and overweight, that just giving them 5 brochures over the course of the year significantly led to significant amounts of weight loss, as well as increases in physical activity. So it doesn't have to be the whole thing. Just a little touch is good.
So we want to finalize our main talk, with some tips and strategies for implementation. And again, these are just ideas. They don't have to be done in any specific order. They don't all have to be done, but these are some simple, accessible ways to implement guidelines into whatever area that you work in or live in as a cancer survivor. So if you're a clinician in any capacity, or even in an allied health field, incorporating lifestyle related questions in your intake forms or assessment forms can be very beneficial. Patients will tell you if they have interest or concerns related to fatigue or function or falls. And so incorporating a way that they can include this information and then you can talk about it can be a great opener to a 5As. Giving patients details about not only how they move, but just general information can be helpful. But we really recommend when possible to provide specifics. With the newest guidelines, we have a lot more specifics related to the questions that people ask. So when we open that door, giving them an encouragement of this is how much exercise you could start with or should start with, or some ideas of fruits and vegetables and quantity, gives them something that they can tackle, very similar to how we would use personalized medicine, but in this lifestyle strategy. We think it's really helpful to create warm handoffs when possible, referring over to members of your care team, such as a dietitian or a rehab professional. Trying to send these referrals for the patient so they don't have to make those phone calls is also definitely helpful, but not required. But it does support, as we've seen, patients taking the next step. I think it's really key to take some time when you're thinking about these resources to create a toolkit. Pull some of these brochures or educational collateral, have them available in your clinics. And when those questions and conversations happen, you're able to give that patient that resource immediately at that point of care, which is helpful that they are definitely feeling that they're excited about it and you know that they're getting the information that they need. If you document into your notes about maybe a conversation or a topic about the 5As, that'll give you that opportunity when the patient comes back in for their follow-up, whether that's in 2 weeks or 3 months or whenever, that you can follow up to that question, creating future conversations. And then lastly, we know that we all are limited in resources. So look into your community partnerships for potential gaps. Even if you don't have them in your health system or organization, there are great professionals with diverse skills that can be very useful for you as well. So moving into this last few slides, we have pulled together a handful of resources. We will make sure that for anyone who has registered, you'll have access to the links directly for all of these resources so that you can follow up as quickly and as effectively as possible, because we know we're all limited on time. But here's a few from some very strong cancer organizations, including Livestrong, the American Cancer Society, and the AICR, all of which we highlighted through our conversation today, giving great resources for cancer survivors around lifestyle and behavioral change. In addition, there is some specific exercise resources. In addition, there was also another webinar led by Dr. Katie Schmitz with NCCS in October, highlighting the exercise oncology resource and needs and direction here. She has helped pull together a couple of these resources I want to bring your attention to as well. Number one, Moving Through Cancer is the main initiative from the American College of Sports Medicine. This resource online has an incredible directory of programs that are available in many communities throughout the United States and broader, both in person as well as online. So if you're looking for a resource in your community, this can be a great place to start. In addition, this resource I'm showing you on the right is a new patient education piece that's in PDF form that you can use that introduces exercise and gives a lot of also key strategies as a great talking piece when you're implementing the 5As and exercise.
And as far as diet, nutrition, and healthy weight, there is a lot of garbage out there. So, and many of your patients will probably bring up this garbage to you but here are some reliable sources. So My Plate is a good source. The NCCN brochure on healthy living is a good source. And the ASCO, Managing Your Weight After a Cancer Diagnosis, is a good resource as well. And then lastly, I want to say that always keep in mind that there may be some studies that your patients can tie into. And this is kind of a shameless plug for our Amplify trial. It is a trial of 652 cancer survivors across the United States. We are recruiting individuals who have these 8 cancers here. So breast, colorectal, endometrial, kidney, ovarian, prostate, thyroid, non-Hodgkin lymphoma, and then also multiple myeloma. Why are we really targeting these cancer survivors? These are all obesity-related cancers. So this has the umbrella that they provide there. We have developed a great website that we provide individuals with 1 year of support. They move through with weekly sessions We're seeing great results in the 400 people that we've recruited, but we need about 200 more people. So if you have one of your patients that is a cancer survivor is getting done with treatment or is done with treatment, please keep us in mind. It not only could hopefully benefit them, but then also we do track patients and we can give Commission on Cancer credits, cancer control credits to you in your institution. So please keep us in mind. And with that, Sammy and I will take questions, and we thank you for your attention.
Thank you so much. That was amazing. So much really great information. And we have a lot of questions, so I'm going to just jump right in. So we know that there's weight stigma and bias and some both explicit and implicit discrimination in healthcare among providers, and that can be associated with poor physical and emotional outcomes. So this question asks if it's not time to shift the strategy to focus more on healthy eating and lifestyle behaviors versus weight and BMI. And there was another question that was similar, but saying, should we focus just more on the behaviors than about weight loss for weight loss sake?
Yeah, these are great questions, right? Truly, it's a little bit softer approach if you say, I really want you to increase your fruit and vegetable intake. Those are low energy density foods that are high in nutrients. They're one way that you can cut calories overall. And then also the physical activity. It's an energy sink. Now, granted, physical activity is good for weight maintenance. It's not good for weight loss. You have to exercise a heck of a lot to work off 9 jelly beans. So it has its benefits. But when patients say, geez, I think there's a popular commercial on TV that says, I exercise for every day for all my life, and I still haven't lost a pound. Well, yeah, because exercise really isn't associated with weight loss. It's really good for stabilizing your weight. So yes, you can approach it that way. However, the data are so strong with weight that eventually it's probably, again, it's the number one recommendation. I know it's sensitive. I know that it's a hard message, but somehow we have to get into that message. It's almost like alcohol, because I participate on the NCCN survivorship panel, and people are ready to toss me in the garbage because I say, the data are what the data are. And for alcohol, they're pretty strong. And we need to give patients the data. They deserve the data. And so, yeah, you can get around it through the back door. That might be a starting strategy, but eventually the message has got to get there.
Okay, thank you. I feel like maybe you were watching me when my camera was off because I was eating some jelly beans. But now I have my exercise I have to do to work those off.
You better get going, Shelley. It's going to take an hour of it.
Okay, so this next question is for Sammy. Can you address the challenges and best practices for implementing the exercise and nutrition guidelines in a hospital center? And what are the challenges and how cancer centers successfully address those?
Well, I would say probably the number one thing is to go back to what we have for guidelines. I mean, I think it's going to be really hard to implement everything, but we understand from working in the cancer centers, again, fatigue. So we really target looking at the guidelines and addressing some of the main side effects that our patients are reporting. So fatigue is one. We would do an emphasis on chemotherapy, peripheral neuropathy. So any patient that we know is going to undergo one of these types of medications, we educate them that staying active can help mitigate potentially the CIPN, or it can help them stay safe. So I think probably the biggest advice that I can give people is we need to think in the language of what a clinician thinks about and the way that they manage side effects. So talking about exercise in, the way that I like to talk about exercise may not be the first strategy, but looking at it in a way that makes sense to a clinician is going to be key. And then making sure that we're measuring it, utilizing COC criteria or NAPBC criteria is also very, very helpful in a healthcare setting.
Great, thank you. I'm combining a couple questions about processed foods. So can you talk about processed meats, and does that include chicken and turkey sausages? And also, can you talk about ultra processed foods and how both of these relate to cancer?
Yeah, so those are both great questions. So with regard to processed foods, it's anything that really contains nitrates. And so therefore, turkey loaf is just as damaging as a piece of bologna. And so that doesn't mean that you can't have lunch meat. You just have to be very careful in reading the label. And then getting like roasted chicken or roasted turkey without nitrates or nitrites in it. As far as ultra processed foods, this is a new buzzword, and we are starting to, the data are accumulating right now. They're not as strong as, perhaps other areas, but yes, you need those foods that really have almost no nutritional value because we have processed them to the point of taking out all their fiber, all their vitamins and minerals. Why do that? Now, in some cases, through processing, you take those out and then you put it in with some added vitamins and minerals. We know that in our studies of food supplementation, dietary supplements, we often don't get the formula right. And that's why things like the alpha tocopherol beta carotene trials, ATBC trials, select trials really were a cigar that blew up in our face.
In the obesity and relative risk chart that you showed, it didn't have all types of cancer, so like lung was missing. Is there still the same correlation? Do we have data on other types of cancers?
No, the 13 different cancers that are there are really the ones that are considered obesity related.
Okay.
Lung cancer is not an obesity related cancer. Melanoma is not an obesity related cancer. There's other causes for that. And, it's just like with the clinicians out there, there are some treatments that respond to some forms of therapy and not others. Well, there are some cancers that respond to some exposures and not others.
Okay. Can you talk about eating disorders with cancer survivors? And also, what about patients that value weight loss during treatment and may be too thin? I know we talked more about weight loss.
So
the opposite.
with, one does not want to switch one problem for another problem. Oftentimes, cancer survivors aren't really necessarily our highest risk population when we impose a diet. It's not like I'm a dietitian in a hospital and I start to work on my counseling on a teen that is overweight and then is likely to rebound into bulimia or anorexia, which is a much higher risk population, but it does happen. And and quite frankly, with our Amplify program, a lot of our messaging that we program into this website is, oh, getting a little bit low, time to put on the brakes. So we don't want people to get under a BMI of 18.5, which is where they're really going. The risk of deficiency and risk of opportunistic infections is going to be much higher. We want to keep them in that, that BMI range of, and quite frankly, I don't really like our cancer survivors to get to 18.5. I kind of like that little cushion of 20 to 25 is the ideal weight range. Again, most of our survivors are over that, right? So we just want to push them down toward to losing a sufficient amount of weight that's going to make them healthier.
And Shelley, I would add to this too, not to interrupt Dr. DeMark, is that, I think that patients need to understand if they're in treatment that, if they're losing muscle or they're losing weight during treatment and they're not very active, they're likely losing a lot of muscle, which we have more succinct ways of assessing that. But it's giving them the short-term versus long-term strategy and focusing on maintenance and lifestyle behavior during treatment that we've seen to be much more successful. But I will reiterate, we see this in clinics all the time. Someone has a really aggressive cancer. They're like, but I've lost 10 pounds, and they are a little bit excited. Shows you that they are focused on obesity and weight management. And sometimes it is a good conversation starter, but giving them appropriate guidelines and parameters of how to lose weight, when to lose weight as well.
And I just want to jump onto that. One of our patients in Amplify lost 30 pounds. She was so proud of herself. She went into her oncologist, and the oncologist said, "Oh my God, you lost 30 pounds." and she had to say, "I worked hard to lose this 30 pounds." And, because let's face it, weight loss that is unexplained is a harbinger of disease or disease progression. Mm-hmm. So we do need to be mindful of that. But in our patients and in our patients that are trying hard, they do need reinforcement. If they've made some lifestyle changes that are good, pat on the back. You're doing great. That's fantastic. But yes, you do have to make sure that they lost the weight because they were trying, as opposed to not trying. Yeah.
I think that's really important too, because it can be really hard to be trying and not having success. So if you get some sort of acknowledgement and that your healthcare team sees that you're really working at it, that can be very motivating. Well, we have more questions we didn't get to, but we are past the top of the hour. So I want to thank you both so very much. This was really incredible. And I appreciate the resources that you shared, and we will be posting those resources along with the slides. This was really helpful and very, very important information. And I can't thank you enough for joining us today.
Thank you. We appreciate the opportunity.
And thanks for everybody for listening today.